Welcome to the Pharmacists Are In, a podcast made for pharmacists by pharmacists. Pull up a seat and let's get started.
So we are back. Pharmacists are in. John Papastergiou, Ajit Johal, and we've got some new music.
Did you hear that theme music?
Oh yeah, I did.
Still young. You know
Still
what
young?
that is, eh? Yeah, they're good
I
DJs.
do. Yeah. So kind enough to mix down a track.
Yeah, custom intro for us. That could play at Tomorrowland. You never know.
It could.
It's
It
gonna
could.
be it's gonna be big. Today's topic, we're continuing on the immunization theme. I think we're gonna kind of switch gears a little bit. Talk a little bit about COVID. Talk about influenza.
Yeah, we've got a really nice respiratory disease series going. So 3 episodes. We're gonna kick this one off with COVID-19 and influenza.
You know, this is what pharmacists are focused on right now. I mean, immunization's become such a big deal for the profession, and not just here in Canada. I mean, we've been doing it for a while, but the Americans have been doing it for a while. But some of the other countries across the world, they're just getting going. I'm doing a talk virtually the Canary Islands in Spain later this week, and that's what they want to hear about. Like, how did you guys get immunization going? How did you get it off the ground? And where do you guys think this will lead? And I think it's interesting to, the successes we've had here in Canada. It's interesting globally.
It's very remarkable. And I remember we were doing a presentation last month in Toronto, and you said your word of advice is to all other countries who want to mobilize their pharmacists is it starts with influenza.
Yeah.
It really does. And that's how it started here. And then with the COVID-19 pandemic, now pharmacists are doing the majority, the lion's share of COVID-19 vaccines as well.
Oh yeah, I remember back the first year we were able to do immunization in Ontario for flu. I was part at that time. It was part of we called it OPEN, the Ontario Pharmacists Evidence Network. It's referred to now, but we were tasked. There was a group of us tasked with quantifying that impact that pharmacists had, and we had a number of publications at that time. Great people out of University of Toronto, Waterloo, Cheryl Lynn. We had a whole team there. And, I remember that when we pulled the data, because that data was, we were doing immunization everywhere. So it was very hard to aggregate data, and we had to pull it, from different sources and public health and everything else to compare what we were doing. And how many shots, it wasn't a full season too, the first year, but how many vaccines do you think we gave in Ontario flu shots that first season?
If I were to hazard a guess, I'd probably say Ontario's a big province, so probably like 2 million.
No, not even close, because many of us weren't even trained, right?
Gotcha.
So we didn't have
Okay.
so many sites. So I think we did, if I recall, 250,000. It was nothing. And
Wow.
then, we heard, okay, so we know we got the scope. It was mid-season, and all of a sudden, flash forward next year, we ramp up huge. Everyone gets trained, and all of a sudden, we open the doors to flu season the second year, and you're right, we're like well over 1 million shots, right? And it's just continued to grow from there, I think.
And it also, when you look at actually I think it was 2018, 2019, where CPHA did that survey where most Canadians, adults, get their flu shot at pharmacies. And Ontario is obviously a big chunk of that.
It's the destination now. I mean, I think the physicians just send them to us. I met many physicians, although some may do, seniors vaccine, high dose, this, that. I think they're, one of the limitations early on was we were worried about that turf battle. And I think that, is always an issue. It's an issue right now in these other countries we refer to. That's always their first question. How do you get over it with the physicians? And my advice to them is they get over it pretty quickly.
Well, there's more than enough work to do.
Yeah.
You kind of forget with all the other things that you're doing in primary care, that's for sure. But let's reflect, because we're kind of in the spring, summer, and we've had a chance to go through talking about influenza and COVID. Influenza has a seasonal distribution, and pharmacies are very, very almost to the point of PTSD, I would say, where they understand that it's going to be busy with influenza vaccinations. And COVID, we'll talk a little about the epidemiology in a little bit, but We haven't quite settled in that sort of clear pattern, but we do see more cases and transmission and disease hospitalizations from COVID in the same sort of seasonal distribution as influenza. So going through the past season, pharmacists, they gave a lot of flu shots, gave a lot of COVID shots, and they gave a lot of both of them together.
Yeah. I've got co-administration data out of our network, right? And I mean, it's an estimate, but I think, when we started, we were thinking co-administration would be sitting around 30%. In reality, it was over 60, So we did a good job. Some patients came in expecting to get both, but I think a lot of the time it was the pharmacist, right? I'm here for my flu shot. Oh, have you had your COVID booster? No. Okay, let's do it now.
Oh, it's convenient.
Yeah, and I tried to really get my technicians to ask it at the top end. So we had it, prepped, build everything done, because inevitably if I got into the counseling room and then I'm the one asking and they say, yeah, and now the workflow starts again,
Yeah,
and
yeah.
it really
Great point.
disrupts the workflow. So I really, encourage technicians, ask at the front end, saves you a ton of time. It's even in the guidelines now, right? Co-administration, optimization,
Oh,
optimizing
definitely.
immunization.
And we've got some great data. The NACI, well, there's been a couple NACI statements on COVID vaccines, guidance on additional vaccinations. The spring one came out in January. So actually we're kind of in the thick of spring boosters
Yeah.
for high risk patients for COVID. But then the fall statement has also come out, and it's very similar to the fall statement of last year. But the thing is, we have more data, and really the top things that we can tell our patients is addressing their top two concerns. And obviously the top one is it safe for me to get both these vaccines? And we see that there's no increased safety signals, and even reactogenicity is driven by the more reactogenic vaccine. And how I explain that to patients is, if I give you your COVID shot and your flu shot, one of them, typically COVID is going to give you potentially more reactogenic side effects. That would be like sore arm, potentially low grade fever, things like that. The COVID one, if it's going to do that, it's going to be the same phenomenon as if you got COVID by itself or COVID and influenza. So you might as well get protected sooner and not have to come back again. So that reactogenicity is driven by one vaccine. It's not compounded by both of them.
That's an important point, and I still hear pharmacists, and I think I've probably said it as well, might be a little bit worse if you get both together.
The data doesn't.
It's
driven by the one that's going to do it is going to do it, whether you do it with another one or not. And
so therapeutic parole, guys, from today is immunogenicities driven by the most immunogenic vaccine. I kind of learned something there.
Yeah,
I don't think I knew that. I think I was telling my patients the same thing. Like, it could be a little bit worse, but
Yeah, I mean, everyone's different, but again, it's going to be they're independent events.
Yeah, that's right.
So you might as well. It's like wisdom teeth, right?
Yeah.
If you're going to get them yanked, you might as well get them all yanked out once, right? So it's going to be the same procedure, and that one tooth that's going to take like longer for the dentist to do is going to take that long, and the other ones just kind of fly out, right?
Yeah. So you mentioned NACI in the statements that came out. So was there any difference in the fall statement to, when you compare it to the fall statement of last year? Because I think there was, but maybe I'm wrong.
Yeah. So kind of like I like to break it down into like the who, the what, and the when, and things like that. So the who is still the same. So there's a segment of individuals, and you know this, John, you've done a lot of presentations with NACI. There's like should and may.
Yeah.
Right? Where should is like a strong recommendation where you as a provider actually are accountable to actually recommend vaccination. And that's our same high risk groups as we saw in the last statement. So that's, those over 65, those living in congregated living, those essential workers, first responders, pregnant individuals. There's a longer list. We do have it in the reference section. The one thing that has changed, and this could be something that we may be looking at in the fall of next year, is this season for both spring and last fall, we were using a XBB monovalent vaccine. Okay. So the XBB monovalent targets the XBB.1.5 Omicron variant. And that just kind of gets us further closer. And these things mutate at a rapid rate, but we get close to it and we get good cross reactivity, cross immunogenicity. Where the next candidate might be going, and we'll know this in a couple months, is the JN.1. So we might be doing a monovalent with a new antigen to get it closer. But it's the same sort of thing. And I think the other key thing is a lot of the patients we're going to see in the fall are going to be the same people we're doing in the spring. So 6 months is the recommended interval, but you can shrink it to as short as 3. That's really important, right? Because you'll have patients who will get their vaccine and they'll be coming to you and saying, I want my next one. And depending on when they got their last one, the minimum is 3 months.
So when we think about vaccine innovation and everything else, and I understand the underlying logic behind why we have to give these vaccines so frequently, is there going to be a time when we see some technology where we won't? Because I'm starting to think of the cost of administration, all this. If this is happening every 3 to 6 months, I mean, there's a lot of resource being put behind this. Is anything in the pipeline that you may know of that may allow us to go further with respect to our intervals? Because I'll tell you from the front lines, we're starting to have to deal with those questions.
Definitely.
I've had way too many vaccines. I don't care what you say.
Yeah.
I'm being over vaccinated. You guys are nuts. You're just making money on this. I've heard that too.
Oh yeah. No, I think it's good. You want to foster that trust with your patients. And I think it's one of those things where you get these sort of mucosal viruses like influenza, like COVID-19. It's very hard to have long-lasting protection against infection.
Yeah.
And it's very hard to have long-lasting protection against severe disease for high-risk individuals. So, it's kind of like this novel coronavirus, right? Where it's here to stay. It's in animal hosts like deer. So it's got to kind of roll in the same conversation as influenza for the foreseeable future.
Yeah. So I mean, then we're back to that discussion. It's going to be really about health promotion for the pharmacist, myth busting,
Yep.
and advocacy for vaccination and education. I think those are going to become. They've always been important, but I think it's going to become more and more important because you see with who's coming in to get vaccinated, right? And I see there's a clear distinction now. We see the elderly, we see the senior patients, we see the patients with multiple comorbidities, but beyond that, it's dropping off real quick.
Yeah. And I think that those are the highest risk groups. Yeah. So we definitely want to make sure that they are up to date on their influenza and their COVID-19 vaccination, because we are just getting more and more information on the burden of these illnesses. And we'll talk about flu in a little bit. But to your point, the younger cohorts, we know that they're less at risk. So what are some reasons why someone who's young and healthy should be staying up to date on their COVID-19 vaccines? And really, there's 2 clear reasons that were actually in the last fall NACI statement and made their way into the current statement as well. So the first one is transmission. So if you go back to the original phase 3 trials for all these vaccines, it was vaccine effectiveness against infection, disease, hospitalization. And transmission wasn't studied. And, people were taking to social media saying getting vaccinated for others was a lie. Transmission was never studied in the phase 3 trial. But that's not the standard. Vaccine effectiveness is not vaccine effectiveness against transmission. Now, with so many people getting vaccinated and so much COVID testing going around, we ended up getting that data. So vaccination has been shown. It's a good Belgian study, big registry of individuals, good inclusion criteria, know exactly who got vaccinated, who got infected, and how their family members got infected. And vaccine effectiveness against transmission was higher when someone was vaccinated up to date. So within the past 6 months, then we saw the VET go up. And then obviously there's less likely they're able to spread it. So protecting others is a real thing where when you're vaccinated, you have less viral load shedding and you'll spread it less. So people. Now, I'm always a little bit cynical because in North America, we don't, we're a little bit selfish, right? So doing stuff for others may not be the sole driver. The other one is post-COVID condition, also known as long COVID. Reducing your risk of getting the disease in the first place, the infection, reduces the chance of long COVID. And in the most recent fall NACI statement, there is a line in there that says there is evidence showing that those who've had more doses of a COVID vaccine have a lower risk of post-COVID condition. Wow. So it's kind of we want to prioritize who's going to be the sickest of the sickest, but there is certainly a benefit. So I don't think people should be turning away people who want to get vaccinated. But who are you going to invest your time and energy on? It's going to be your high risk patients.
Yeah, for sure. And I mean, we're starting to see this younger cohort in our pharmacies more often. We did a presentation together where we really talked about that, right? Whereas historically we'd see the seniors chronically ill more often, but now with minor ailment prescribing, we're starting to see a lot of those younger patients with historically might be in our stores, but they're not spending a lot of time talking to their pharmacist, whereas now they are. And I think that's a unique opportunity to try to tackle some of these myths and to try to really promote vaccine education. So I think for pharmacists that are out there that are having these discussions, it's definitely an opportunity.
It definitely is. It's always one of those things like, what have you done to become a healthier version of your former self, right?
Yeah.
And staying up to date on your vaccines makes you healthier.
Yeah,
It really does.
for sure. And then, I mean, so we touched on COVID vaccination. Flu's still a priority for us, and I'll tell you from my perspective, my staff even start talking about it in the summer. We're like, there's no vacation during flu season. No one's going. It's blackout, and they're the ones that are saying it because you don't want to be that tech or that pharmacist that's left behind. Everyone takes off, and I know it. You're going into the holiday season and everything else, but it's the now I call it the calm before the storm because it gets busy real quick.
It does. And, I mentioned earlier that most Canadian adults are getting their flu shots at pharmacies, and that just keeps trending up. But what's also really, really important, and this is good for our global colleagues as well, is that the flu shot, every year that we do it and we look at the data, we look at the evolving evidence around it, it becomes more and more valuable of an intervention. It's based on how bad influenza disease is. So going through a couple points here, what do we know about influenza? And a lot of people think it's just kind of like the common cold, right? But if you get influenza, it's influenza. So what do we know about influenza? We know that it's linked with premature cardiovascular events. So influenza causes vascular events and major cardiac adverse events. And we started seeing some epidemiological data that in the influenza season, there was a higher risk of heart attack and stroke. Just like, are people shoveling more snow? Because that'll do it too, right? Shovel that driveway, right? But, during the influenza season, we're seeing more heart attack and stroke. So there's this sort of correlation, but then the causation was established actually from Ontario physician Jeff Kwong. So his big study showing that your increase, especially in adults over 65, because again, that's what you need. You need all the ingredients for a heart attack or stroke. You need streaky arteries. You need high blood pressure, maybe a little diabetes, where you get a bit of narrowing of the arteries. And what happens with a case of influenza, and especially if you're unvaccinated, your body's going to fire up a ton of cytokines. It's going to do whatever it can to kill the virus. And those cytokines, they have unintended effects, especially when they're unattenuated. You're vaccinated. It's like an orchestra where there's a conductor saying, this antigen fires up, but it just goes haywire, and that can actually break off plaques. And that study showed, and that was a landmark study, it was published in the good old New England Journal of Medicine, and it showed that in the first week of a influenza infection, adults over 65 had a 6 times increased rate of heart attack. So influenza, the heart attack virus. So it just shows that it's got this massive impact on this major event that happens in the body.
I think that's therapeutic pearl number 2, for today's segment. I think that's another thing. I think some pharmacists may be aware of it, but I don't think many of us are communicating that back to the patient, right? And we know how many of our patients are at risk for cardiovascular disease, cardiovascular events. Anyone doing point of care testing right now sees how poorly controlled many of our lipid patients are.
Oh my goodness, else. Part of the chronic disease management strategy.
Yeah, so
like our last episode, right?
This is a huge opportunity, folks. So, once you're seeing these patients, make sure you convey that back. That may be one of those drivers that gets someone that's kind of on the fence to kind of flip over and get vaccinated.
Let's give therapeutic pearl number 3 to get them well over the fence. And this goes to Statistics Canada, especially for baby boomers, older adult patients. What do they value most? Friends, money, or independence?
Oh, independence.
Independence.
Yeah, for
Yeah. Oh,
sure.
yeah. Like that's a generation that's out and about. They value being able to take care of themselves, continue doing the
Yeah,
things they're doing. Disability.
yeah,
Influenza infection increases the risk of functional decline
yeah.
and increases frailty. There was a study in the Canadian Pharmacy Journal, little shout out there, where pharmacists we need to do more education about what frailty means, and pharmacists need to be better educators of communicating what frailty means to their patients. And what better resource to use than a diagram? So, in our references section of our episode, there is the frailty index, which kind of shows visually how the frailty scale works and how that affects people. And it's really remarkable how, in going from losing a couple activities of daily living, your life changes. So, influenza, the life changing virus, John.
Oh yeah, and then your life changes, and then I've seen it happen with patients in our practice, and then they just deteriorate after that. So
Yeah.
these are patients that were otherwise, independent, out there doing things, having fun,
Yep.
walking around Greektown. All of a sudden they're, homebound, and then 6, 7 months after that, they're a lot worse.
It's very unfortunate. So
So
powerful intervention from
yeah, so
pharmacists.
that's our third take-home message. I wanted to ask you too. We're talking about flu. What's up with bird flu? Like you're starting to hear it now.
Yeah,
Yeah,
yeah.
are we concerned about this for next season, or what's going to happen
I
there?
mean, I hope it's not an issue. I mean, that's scary when we see a new antigenic shift and we see the ability of. So right now we're seeing the potential transmission from animal hosts to humans. We're not seeing transmission from human to human.
Okay.
So, the more times it goes into a human and that human's around other humans, perhaps there's that possibility, but that's not the case. So hopefully it stays that way.
So, and if it doesn't, we're looking at potentially another pretty bad season, a pandemic. What happens then?
Oh, don't say the P word, John.
Yeah,
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 yeah.
it's banned.
Yeah. So,
But it could be real bad, and I mean, we talked about that, and you've heard experts say like, this what we experienced with COVID. It's not going to be the last example of it.
no, no, it's not. So, something to keep our eye on. But I think at the end of the day, what we should be imparting on our listeners is not scaring them with bird
No,
flu,
yeah.
but what are some things that you're gonna do next flu season? Because you got to start thinking about it now.
Oh yeah, for sure. I
Yeah.
mean, I think anyone that's has a busy dispensary and does a lot of immunization, it's there's a lot of pre-planning coming in, and I think
Totally.
we spend a lot of time now with kind of trying to really think about how we're going to implement some of our electronic solution
Yeah.
scheduling, all that stuff. I think that's important. Again, we try to prioritize our high risk patients early on, get them in fast, get them vaccinated.
Hmm.
There's always this run on the high dose vaccine as well. You see it where, it's generally out in the first couple of weeks. I mean, we haven't talked a lot about some of the distribution challenges we've had in some of the provinces.
Yeah.
And
Yeah.
it's different in every province, but it's been tough. We got a lot of media attention in Ontario around distribution and who's getting what. I think we haven't solved it. I think when we started in Ontario, it was, you know, distributed through the province directly, and then we went to distribution through the wholesalers, but we
Hmm.
haven't really had true self-distribution where we just distributed like everything else. I think if we
Yeah.
could get to that point, it would be bad. And I get it, there's concerns of hoarding and over ordering and all this stuff, but the reality is we do a pretty good job with all the other vaccines that are out there. And I think
Definitely. With COVID
there's
as well.
solutions to it. Yeah,
Yeah.
like and I think it's more important that we get vaccine to those locations that are doing a lot, and then to those locations that aren't doing a lot but have no vaccine.
Yeah. Yeah.
So you've got to get some fair access there. But so I'm a super high volume store, and I can run out of vaccine in 3 days.
Oh, definitely.
Yeah,
Definitely.
and I think it's important to kind of plan for that as well. And I think a lot of that's happening behind the scenes, but at the store level, make sure you're staffed. Think of what you're going to do with respect to workflow, operationalizing the entire process, and make sure you have enough people in the right spots,
Oh
because you
yeah.
can have people, but if you're not playing the correct role, it could be more chaotic than actually efficient.
Oh yeah, definitely. And I think the two things I would probably say is The first one is be adaptable to supply challenges. Don't overbook your appointments. Take your walk-ins, take your opportunities to vaccinate, but don't overcommit because you don't want to be canceling appointments. That's the worst possible scenario.
Yeah, it pisses everyone off.
It does.
Sure.
So you can't control distribution. Anticipate the challenges and roll with that. And the last thing I think it's a nice segue into the next two episodes is be a year-round vaccinator.
Yeah.
Right? I mean, you see people like, I haven't given a vaccine since flu season. They're kind of fumbling around, bouncing it off. They forgot to take the cap off. And it's like, all your patients that are going to be making a run on for high dose in Ontario, for in BC, we have the adjuvanted vaccine options for older adult patients, but they need an immunization plan, right? So, shingles, pneumococcal, RSV, flu, COVID, right? So you gotta rule in a yearly. That's how you sustain it.
Yeah.
You gotta pace yourself.
It's like any other clinical service. If you don't do it, you get rusty. And then people that are rusty don't want to do it. They want to refer it to the pharmacists that do it all the time.
Yeah.
So worst thing that you can do, and I still see that with other vaccines, you get the night pharmacist, is busy. Just come back in the morning. The guy in the morning will do it, and they don't come back, right? Yeah. So you've lost an opportunity. And I think, we've become more comfortable, I think, as a group pharmacist, but there's definitely a lot of opportunity still. So let's see if we could break some records this upcoming immunization season.
I think so. Yeah. I think so.
Maybe with that, we'll call it an episode. We'll be back soon, probably continuing on the same theme.
Definitely. Catch you next time.